May I call Professor Samir Naim, وهو غني عن التعريف. He will talk to us about Panhypopituitarism. Professor Samir Naim.
Thank you very much, Mr. Chairman, Professor Abbasi, Professor Sohail Saeed. Thank you very much. Allow me first to thank Professor Fahmi Imara and Professor Talat for inviting me and giving me the opportunity to share with you with this interesting and very distinguished Congress. I will be speaking today about hypopituitarism, and when we speak about hypopituitarism, this will remind me back when I was a junior resident in the late 1970s in the Department of Medicine. At the time, Alexandria was like that. This is Ramleh Station, very beautiful Alexandria. And I was confronted with this 28-year-old lady. She has presented with fatigue, dizziness, decreased appetite for several years. And she has had amenorrhea since her last labor. This was 8 years earlier. And she failed to breastfeed her child. She looked quite ill at that time, pale with very low blood pressure. And she was treated with L-Cyroxan, prednisolone, and estrogen progesterone pills. 6 months later, she was a completely different person. She was able to serve herself, to serve her kids, and her husband. And this patient actually, she turned my life. So that's why I have chosen to continue in endocrinology. And obviously, you recognize this case. This is a typical case of Sheehan, postpartum hemorrhage leading to postpartum necrosis of the pituitary. And this was described by this UK pathologist. It was described in 1937. And obviously, you remember that this is a pituitary, highly vascular, with two arteries, superior hypophyseal artery and inferior hypophyseal artery. And in pregnancy, the pituitary is almost double size and encased in the bony prominence. So in this case, if you get postpartum hemorrhage, you get ischemic necrosis and sometimes even hemorrhage in the pituitary. And this is from the net. This is immediately after labor. The pituitary is big, and after postpartum hemorrhage, it's becoming smaller, and even it's very small. This is what you call empty cell. This is the pituitary stalk, and this is the same patient with pituitary stalk and very, very atrophic pituitary. This is Sheehan syndrome. But actually, the first case of hypopit in the history was described by Maurice Simmons. He was a German pathologist. This was in a publication in 1914 where he described a patient, post-mortem. She was 46 years of age with amenorrhea, weakness, signs of rapid aging and anemia, and the pituitary, as you see, was quite atrophic. But the first description of the pituitary was back to the Greek Galen, and this was 129 to 10 AD, this after Christ. And he described the pituitary as a gland secreting mucus. So this is in Greek, pituita means mucus. And it was believed the pituitary gland was responsible for secreting mucus. That's why it's called the pituitary. Even in Arabic translation, we call it al-ghudda al-nukhamiyya. Al-nukhama means balgam or mucus. So up till now we are, so if you are asked, why do you call it nukhamiyya, now we can answer our patients. The prevalence of hypopit is not very uncommon as we thought. This is a study from Spain. It's about 50 patients for 100,000 population. So this is not uncommon. And you have to think about it because it is a killing situation with premature mortality, and the risk is higher in women and in younger age. And the causes of hypopit are numerous, but we have to remind ourselves that pituitary tumors, different types of pituitary tumors, even before surgery, can lead to hypopit. Other tumors in the pituitary, like craniopharyngioma, metastasis, effect of irradiation to the brain or to the pituitary, and inflammation, including tuberculosis, sarcoidosis, and histiocytosis. And at this point, we have to give homage and remember one of our patients with hypopit who passed away last year in a tragic car accident. And actually, we use this gentleman for teaching generations of medical students about hypopit. And this was his X-ray. We've got calcification in the base of the brain due to tuberculous meningitis, leading to hydrocephalus, and this is a remnant of the shunt. And we have to give homage to this patient. Again, another cause is azimuthal hemorrhage in the pituitary adenoma or ischemic necrosis like in Sheehan syndrome. And most important, we have to remember nowadays with the car accident and with different type of sport, we have to remember the TBI. TBI means traumatic brain injury. So whenever you read TBI, this is traumatic brain injury. Not only traffic, but different sports can lead to repeated injury. This can challenge the pituitary. And you have to suspect it because early recognition is important because the manifestations are very subtle, very mild. And this now is considered one of the commonest causes of hypopit. You can get after trauma diabetes insipidus, which can be transient or permanent. And also in this patient, the other pituitary hormones are affected. This can occur acutely or even after years of the TBI, years. So we have to remember that patient exposed to repeated trauma, we have to remember whenever they have manifestation of hypopit. Another important thing to remember about pituitary is what we call immune hypophysitis. Particularly that nowadays we are using a lot of biologics, a lot of immunotherapy, MAB, all this type of drugs we are using all through. These can lead to hypophysitis and with enlargement of the pituitary, leading to headache and visual manifestation with hypopit. And sometimes you can, in Alexandria, and I think either in Cairo, they have the facility to measure the antibodies, but you have to suspect it once in this situation. A big pituitary with hypopit in a patient receiving this type of drugs. And the role of steroids is magic. This is one of our patients we have seen in July 2010, and she presented with visual defect, and this is the MRI. This is a big pituitary and thick stalk. This is the thick stalk. This is the optic tract. And this is her visual field. And 3 months later, after steroids, there was a magic bi'idhnillah. Magic improvement, alhamdulillah. Lastly is the genetic hypopituitarism. In the old time, we used to say idiopathic. There is nothing called idiopathic. All this type of fancy genes, and most of us, I think, it's very difficult for us to follow this type of genes, but different sequencing and whole exome sequencing is important to recognize these causes. Let's go to the clinical picture. As you know from the medical school, that ACTFH deficiency will lead to fatigue, weight loss, diminished appetite, and low sodium. TSH defect with hypothyroidism, weight gain with dry skin and sensitivity to cold, constipation. The deficiency of LH and FSH in women will lead to amenorrhea and diminished sexual drive, infertility. In gentlemen, LH, FSH in men will lead again to diminished erection and diminished fertility and delayed puberty in boys. While growth hormone deficiency is not only important for children, for growth, but also important for adults. Because if you lack growth hormone, you can have abnormality in the fat distribution, premature atherosclerosis, osteoporosis, and diminished muscle mass. Deficiency of prolactin, of course, appears only postpartum with inability to breastfeed, like this lady with Sheehan we have seen. Oxytocin, we don't have a different clinical picture, but remember now we call the oxytocin is the love hormone or the emotional hormone. So we don't know a lot about it. Antidiuretic hormone deficiency, of course, will lead to DI, diabetes insipidus, with polyuria and polydipsia. But we have to remember about two facts. That this hormone can occur singly, one hormone, or sometimes multiple. And the old day we used Panhypopituitarism. And also the problem is can be dynamic. So you can start with one hormonal defect and end by multiple hormonal defect. Or you can start by multiple and go back. We have seen cases of Sheehan was able to conceive, and this is very, very uncommon. So we have to remember these two facts. About the diagnosis of hypopit, apart from the clinical suspicion I've told you, although the clinical suspicion is not very strong, you have to suspect it early because the manifestations are non-specific. And if you suspect it, you suspect growth hormone deficiency and ACTH deficiency, baseline level is not feasible because it starts from 0. So you have to do stimulation test. And the old time, we used to do what you call the insulin tolerance test, in which we used to give insulin for the patient to reduce hypoglycemia to stimulate the growth hormone and CRF and ACTH. But nowadays, we've got the most recent is the oral tablet, oral masimorelin, which is a growth hormone release substance, ghrelin receptor agonist, is quite safe and very good results, and it's not available yet in Egypt. And I will continue with the most recent guidelines for the Endocrine Society is 4 years, but it's quite complete. And for the diagnosis of cortisol deficiency with ACTH deficiency, you measure the cortisol in the morning, not in the afternoon. It's useless to measure it in the afternoon if you suspected hypopit. And levels below 3 means that this patient is having cortisol deficiency with ACTH. If it is above 15, it excludes. But in between, you have to do the stimulation test by giving the ACTH injection. For hypothyroidism, if you suspect it, measure free T4 and TSH. And in central hypothyroidism, the free T4 is low, and TSH is not high, not very high. Because if the T4 is low with high TSH above 10, this means that the patient has a problem with the thyroid. But in this patient, you measure free T4 will be low, TSH low, maybe normal, or even a little bit elevated. For the central hypogonadism in men, you measure testosterone is expected to be low, LH-FSH to be low, but remember that we need to measure it in the morning, before 10 a.m., not in the afternoon. And in the absence of any acute illness, pneumonia or flu, because this will lead to low testosterone. In ladies, measurement of estradiol in FSH, LH is not very important because you expect it to be low with LFSH. But you have to exclude, remember, other causes of lack of ovulation, like hyperprolactinemia, hyperandrogenism, thyroid disease, and most importantly, pregnancy. This is the most common cause of amenorrhea in ladies. We have to remind ourselves about this. We have seen many cases presenting with amenorrhea and they turn to be pregnant. The treatment, of course, you have to replace what is missing. For ACTH, we give hydrocortisone tablets, as I will show you, or prednisone, if you don't have the facility to get hydrocortisone. You measure for the TSH, we give thyroxine. For LH-FSH deficiency in ladies, you give estrogen, progesterone pills. For men, you give testosterone. If you need fertility, you give LH-FSH combination for both genders. And for growth hormone deficiency in children, you give also growth hormone. Again, in adults, I show you that data that important to replace the growth hormone, but to use smaller dose. For prolactin, oxytocin, none. For antidiuretic hormone, you give the DDVP or desmopressin, whether nasal inflation or by tablet sublabial or by tablet to be swollen. While the different doses for the glucocorticoid replacement, you use between 15 and 20 milligrams. In the old time, you used to give 25. Now you can give down to 10 sometimes. So you use smaller dose, and you divide it in 2 doses. So you gave 10 milligram in the morning, 10 milligram in the afternoon. Sometimes you can divide it into 3 doses, 10, 5, 5, or 5, 5, 5. And now, we've got the longer-acting glucocorticoid, which is not available yet in Egypt. For thyroid, of course, you have to use thyroxine in the usual dose, 1.6 UG per kg per day if there is total hypopit. And you have to keep the T4 in the upper half. It's useless to measure TSH because TSH would be low forever, even if you use overdose. So please write in your prescription, this is a central hypothyroidism, because he can meet another doctor and he will find TSH low, and you'll tell him, no, you are overcorrected, because he will think that this is primary. Please write, this is central hypothyroidism. For testosterone, of course, you have to correct it, and testosterone not only for sexual life, but it's important for the bone, important for the fat mass, for the well-being, and for the strength. For growth hormone in adults, as I told you, use smaller dose. This is 0.2 to 0.4 in less than 60 years. Above 6, use 0.1 to 0.2 milligram, and you titrate the dose by measuring IGF-1. But please remember that this is not to be given haphazardly. You should give only growth hormone when there is definite hypopit, especially with hypothalamic or pituitary lesion, say post-operative. And mind you that the use of growth hormone does not increase the rate of other tumor growth in adults and even in children. We have to remember that. Lastly, I will end by certain clinical tips of how to use the different hormones if you want to treat hypopit, because there are certain tips. Let me start by the first. If you've got a boy or a gentleman with growth hormone deficiency, you have to test glucocorticoid before giving the growth hormone. Not only that, even after starting the growth hormone. I've just seen a boy, this was a year ago, and after starting growth hormone, he developed cortisol deficiency, so we have to remember that. Number two, the glucocorticoid and thyroid hormone, you remember that from the medical school that you should start first glucocorticoid followed by thyroid if there is deficiency. And if you don't have time or facility to measure the glucocorticoids, just give glucocorticoids first before giving the thyroid. About the growth hormone and thyroid hormones, we know that growth hormone deficiency can be mimicked by thyroid hormone deficiency. If the thyroid is low, growth hormone will be low. And this is corrected after thyroxine replacement. So we have to remember that. Number two, that if you start growth hormone, this can show the hypothyroidism. I mean, we have seen patients with normal thyroid function after growth hormone therapy, they develop hypothyroidism. And if they already had hypothyroidism, we need to increase the dose. Estrogen and thyroid hormone, if the patient is taking both estrogen and thyroid hormone, you have to adjust the dose whenever you start estrogen. Mostly you need to increase the dose. And the same apply with growth hormone. If the patient is having growth hormone and is starting estrogen, you have to increase the dose because estrogen will lead to increase in the growth hormone resistance. You have to increase the dose. Lastly, glucocorticoids and diabetes insipidus. If there is deficiency of antidiuretic hormone and cortisol, the cortisol deficiency will mask the polyuria of diabetes insipidus. So once you start cortisone, you will get manifestation of the polyuria. So we have to remember that. Lastly, but not least, is in pregnancy state. Please do not stop the cortisone. So it's perfect to use hydrocortisone, but sometimes you have to increase the dose, not very much. You can use prednisone in pregnancy, but never dexamethasone. Please, contraindicated, because dexamethasone is not activated in the placenta. So we have to remember that. Dexa, not in pregnancy. And for thyroid, you continue the dose, you have to increase it. Desmopressin, continued in pregnancy, please. Sometimes even we increase the dose, and growth hormone discontinued in pregnancy. And last, we have to think about the future. The future may be brighter than the present, about the different hormones. We are thinking now about pituitary stem cell. And this is different publication, although they are halted. I mean, up till now, we don't hear very much about useful pituitary stem cell therapy by induction of the new pituitary cells. Mr. Chairman, Madam Chair Lady, ladies and gentlemen, we have to remember and remind ourselves that hypopit, although it is an old disease, but it is not uncommon. Presentation is non-specific. You have to know that there are different diagnostic criteria. and attention to the recent immune problem, traumatic problem, and treatment should be tailored. We have to know a little bit about physiology of the hormone. It's not very difficult. I tell the students that endocrinology is the simplest science, because if you know physiology, you apply it and you get to the safe way, inshallah. Thank you very much for your attention.